Hi, everybody. How was lunch? I mean, who doesn't love tacos? Give me a taco. Taco's my boyfriend. We've got a little really special treat, so I am going to start, and I am going to ask everybody. I love the conversations. Keep the conversations going, but if you are, step out. Otherwise, take a seat. We've got a really special treat. One of the reasons that I had wanted our family, my friends' family, to speak this morning is because it's so important that we're hearing from not just beneficiaries of surf therapy, but the truth is it's really important to be hearing from the kiddos, right? Our teens, all the young ones, but the participants. I probably shouldn't have glasses on, rude. So really cool story and very cool poem, and I'm going to let Bob tell you all about it. Come on up, Bob. And then, like I said, you'll just give it to Phil when you're done. Thanks.
Thank you, Chris. Brian Costello, 28-year-old man living with autism. 7 years I've known him. The last 2 years he's come to our camp, never missed a day, and I've never heard him speak a word. Yet, he writes poetry. So I'm going to read this, is what he wrote. Art. Surfing. No, it isn't what you'd call art, but I feel like an artist. Timing the perfect wave, gliding through the air. It makes me feel in my own perfect world. Take me surfing, wash all my worries away with the waves. Underwater, life stops for a second. The world turns silent, leaving me transformed. Pounding of my heart echoes through the water, making my thoughts stop. When I come back to the world, a sense of calm comes with me. Portable serenity. Listening to my heartbeat, chasing the calm underwater. Thank you.
Thanks very much, Bob, for that beautiful piece of art that you shared with us. So my lucky job now is to introduce the first speaker after a wonderful lunch. And it's an absolute pleasure to introduce Dr. Kristen Walter, clinical research psychologist from the Naval Health Research Center at San Diego. And she's going to be telling us all about the mental health benefits of surf therapy and the patterns that underlie them. So really looking forward to this, Kristen.
Thank you. Okay. Can everyone hear me? All right, well, it is day 5 for many of you, and this is the post-lunch presentation. So if you need to stand, you need to exercise, do as you will. I am really honored to be presenting here today, and I just want to take a few minutes and set a few things up before I get into the main part of my talk. So the bulk of what I present today is going to be on common patterns that we found in our surf therapy studies. And so that'll be the main focus, but there are some things I'd just like to start with. The first is that I am very honored to be speaking here today at the Blue Mind Summit. And like many of you have done so already, I just want to recognize the pioneering work of Jay Wallace, who has also informed a lot of the work that I do. And so I was fortunate enough to meet Jay in 2018. And in 2017, we started a research project that was largely founded on his research in ideas. And so one thing I was just very impressed is how accessible he was, how willing he was to talk about ideas. ideas. And so I really just want to honor his inspiration to us, the inspiration in the work that we do. And then I'm very fortunate that he even started this meeting of the minds so that we could all be here in our love of the water. And I wish him water. So I just wanted to start with that. I'm also very humbled to be able to present to you because I am a clinical research psychologist. I'll talk a little bit about the serendipitous path that brought me here, but what I'm going to present today is some research that can hopefully inform how we deliver surf therapy. And so I am bringing in that knowledge and experience today with the understanding that you guys are your own experts. And when I talk about some of the findings that we have and how that may translate into surf therapy, please know that ultimately you guys are the experts in the populations you work with and in the resources, the programs that you come from have. And so I will be mentioning those, and hopefully the intersection of our knowledge allows us to deliver surf therapy in a way that's most effective for our participants. I also have to cover 2 disclaimers. The first is that I am an employee of the U.S. federal government. So therefore, all of the content today is that of my own and does not reflect the position or policy of the Department of Defense, Department of the Navy, Department of Veterans Affairs, or the U.S. federal government. So that is the mouthful that I have to say with every presentation. Thank you, thank you. I've said that more than a few times in my day. So that is the first. And then the second is more of a philosophical and practical disclaimer. Everything I'm going to be presenting today is the science we know now. That is the best we can do. But there is still so much we have to learn about mental health, about treatment, and how people respond to treatment. So everything I mentioned today, it's what we know now. It's a constant evolving science. So that is my philosophical and practical disclaimer. Okay, so with that, I will talk a little bit about what brings me here. So I am a clinical and research psychologist, and for many of you who were at the paddle out this morning, maybe you didn't realize on the paddle out that I wasn't a primary surfer, but maybe on the paddle back in, when I called for a paddle lift, that you were like, maybe that girl did not come from primary surf therapy. And so about 50% of you in this room know the story of how I came to be in this place I am today, and about 50% don't. So I'm going to give a brief story of that. For those that know it, feel free to zone out or do whatever you need to do in the interim. But my whole career has been based on 2 things. To figure out what mental health treatments work, and for whom, and how we best deliver those treatments. So I am primarily a trauma psychologist. In grad school, I worked with inner city populations. Since graduating grad school, I've worked with the military population, both U.S. veterans and service members. Which reminds me, since I'm presenting to an international audience, just a lingo thing. In some countries, I think you use veteran for both active serving and prior serving military. In the US, we kind of differentiate. So I'll be talking about active duty for folks that are currently serving and veterans for those who previously served. So this has been the focus of my research and focus of my clinical practice for my whole career. However, about 11 years at this point, I moved out to San Diego from Ohio, and it was my first week of work. I did not really have computer access. I didn't have any scheduled appointments. And so I was trying to be useful. And when I was talking to my colleagues, I said, okay, got any ideas for how I can help around here this week when I can't do much? And they're like, talking about interests, and found out that I liked sports. And so they're like, why don't you go volunteer at the National Veteran Summer Sports Clinic? And I was like, what's that? And so it's a program that the U.S. Department of Veterans Affairs runs, where veterans from all over the country come to San Diego, and they do 5 different activities for the course of a week. So I'm like, sure. I asked my supervisor, is this something that I can do? And they're like, absolutely, go for it. So I showed up at the venue closest to my home, which happened to be the surf therapy venue. And so don't worry, I showed up and said, probably not certified to teach surfing, as you guys can see, but what do you need me to help with? And so they're like, we need water volunteers. And I was like, well, I like being in the water. That's great. I'll do that. So this gave me a really amazing opportunity to not only help people get on and off board safely for the week and in and out of wheelchairs, it gave me a really amazing opportunity to just take a look around and observe. And what I found was what was going on through surf therapy and what I was watching is what I try and do in therapy. It was just a different medium. So for example, there were veterans who had never experienced the ocean before, let alone the Pacific. And so they would, walk in and get familiar with just the waves slapping their ankles, and then they'd work their way up until they were fully immersed in the water. And so they were doing what we do with anxiety, what we do with PTSD, with exposure therapy. Exposing people gradually to get comfortable and to reduce their anxiety and fear in the ocean. Then I also noticed the sense of mastery. So people came in and they were maybe riding prone and then maybe on their knees with an instructor and then working up to surfing independently, obviously depending on their physical ability. But this was building mastery little bit by little bit. Again, something we try and facilitate in treatment. And then there was this aspect of social support that I cannot facilitate in group therapy like that. What I was seeing out there is not what I can do in therapy setting. And so that led me to think, maybe something's here. And so being the research nerd that I am, I went and took a look at the literature and said, what exists? And there wasn't much. There were a few studies where a lot of this really gained some momentum with individuals with autism or neurodiversity. And I then took a look and saw what's available for veterans and service members, and there wasn't much. There was a case study by Fleischman with pain. There was pioneering work with Carly Rogers, and that was, quantitative work. That was amazing. And then there was some qualitative work by Nick Caddick, and that was kind of it. So I filed the idea, put it away, and about a year later, I started working for the Department of Defense. And grant writing, for better or for worse, is a huge part of what I do. And so I wrote a grant to study the psychological effects of surf therapy. Once that was funded, I reached out, and I'm thrilled that you're here. Betty Mihalovich-Krog is right here. She is my collaborator, and none of this research would have happened without you. But I kind of found out about Betty's program, which was done at our Naval Hospital as part of standard care. It was an option, and so I called you up. You had just gone to the ISA Adaptive Surfing Championships in La Jolla. I called you up, said, hey, you want to do research? You're totally on board, and that has begun our research efforts. And so today what I'm going to present is my group's done 3 different studies involving surf therapy. And they're all a little bit different, but there are common findings that resulted from them. And so these patterns seem to be holding, and so this is what I'm going to present to you today. So I will just give you enough of the methods for you to be able to recognize the similarities in differences. I'm not going to go into excruciating detail. If you want those, I'm happy to talk later, but I won't bore everyone with them now. So this all started with a basic surf therapy evaluation. This was Betty's program, which, let me give you full credit, your program was in existence for like 8 or 9 years before we started working together. So it was a very well-established program. I just came along to help with data collection. And so this program, this was service members who had any physical or mental health reason for referral. It was pretty open in terms of who we included. And the program was 6 weeks in duration. It occurred once a week in Del Mar, California, 3 to 4 hours a session. And participants completed assessments. They were all self-report before and after the program. And because that's not the strongest design, we tried to beef it up a little bit by doing pre and post assessments. So that way we could say, all right, any effects that we're seeing are likely due to the surf therapy session they just participated in. And so this was our first study. And we then, after we finished that one, really tried to beef up the research in the second one. So this is the one that Jay Wallace had some influence in designing. And this was our way to look at Blue Mind. We actually compared surf therapy compared to hike therapy because we wanted to see, does it matter if you're in the water or not? And so what we tried to do here is I use the methods that I use for my psychotherapy trials. So one of the things, if we want medical providers to take these interventions seriously, to think about prescribing them, to go down the route of insurance, we've got to be communicating in the same language and looking at the outcomes that matter to these folks. So what we did was we conducted a randomized control trial. That is really a lot of words for just saying. People who are eligible, we flipped a coin, and they either got surf therapy or hike therapy. And both programs were, 6 weeks, once weekly, 3 to 4 hour sessions. They were both outdoors. They were both in a group setting. They were both physically active. One was in water, one wasn't. So we did the pre-post assessment. We also added on a 3-month assessment. We did self-reports as well as clinician-administered diagnostic assessments. And everyone got an activity tracker so we could monitor activity and sleep over the course of the study. And so really tried to have a lot of different assessment methods, and so we could really see what was going on here. And then finally, things came around full circle, and my team and I volunteered to do a research study with the National Veteran Summer Sports Clinic. And so here, this was a veteran sample. Unlike the others that are 6 weeks, one day a week, this was 1 week, and then they did activities for like 6 hours a day. As I mentioned, there were 5 different activities. Surf therapy was one of those days. And so we did a pre at the start, and then after the week, and then 3 months later. And these were all self-reports as well. Okay, so these are the 3 studies we've done involving surf therapy. And you can kind of see that there were consistent methods. So what we tried to do is we used the same measures across studies. We had pre-post design minimally at all of them. We also added a 3-month follow-up for 2 of them. And so while they cannot be directly compared, we didn't collect them at the same time in the same study, we are able to compare the data and see what patterns emerge. And so the first is that the mental health benefits of surf therapy are time limited. And so routine and frequent engagement are probably our best approach for delivering the best treatment effects. And this was, okay, so let me walk you through these graphs. So one is negative and one's positive, which is why they're in different directions. So the top graph, you see that those are each week. And so folks start high, they decrease, those are depression and anxiety scores. So over the course of the session, significantly go down, but they're at the same level a week later, and then they follow that same pattern. So we know that those results don't last a week. At some point, they rebound, but the same amount decreases within each session. Positive affect is at the bottom, and that's a little bit different. It's similar in that you see each session, it increases, and then it kind of rebounds the next week. The difference is that you can kind of see that folks for positive affect don't go down to the same level. There's actually a little bit of an additive effect where their positive affect starts a little higher over time. But in general, we're finding that these results don't last a week. We also found this with our veterans summer sports clinic, that folks decreased anxiety, depression over the course of the day, but it sort of rebounded the next day. I thought this was very interesting because our talk yesterday with the flotation was saying that, okay, we're seeing effects last about 48 hours. And so this is just recommending that there needs to be frequent engagement to maximize benefits. And Betty, I will take one of your nuggets. Betty says that it needs to be like your daily dose of medicine. And so maybe with the 48 hours, if that is like what it lasts at, maybe what it will be is that you need every other day for your dose of medicine. But in any case, frequent engagement seems to be the most effective way to deliver surf therapy. And I realize that this is contingent on staffing and resources and everything. I get that. But for programs that are able to at least meet weekly, even more frequently would be even better. But if you can do that weekly, that might be a good way to reap those benefits. Another is that there are mental health benefits for surf therapy, regardless of gender, regardless if you have no diagnosis, one diagnosis, or more than one diagnosis. And I'll break that down. So in our program evaluation study and in our surf hike study, we took a look at gender differences. We're fortunate in our studies to have almost a 50-50 split of men and women, which is interesting given that the US military is not 50-50 split. And what we found is that both men and women, and I will say that's a limitation, it was just self-identified as either man or woman. We don't have any other data for other types of identification, so I will say that. But for both men and women, there were significant mental health benefits. But what was interesting is on the few differences where there were a gender difference, they actually favored women. And this is interesting given that surfing tends to be a male-dominated sport, and the US military is male-dominated. And so that was kind of an interesting finding, and we replicated that. We did that in our program evaluation, and then we also replicated those findings with our surf hike study. So across our studies, we looked, there were some folks that didn't have, they may have had a physical or a psychological reason for referral, but they didn't meet diagnostic criteria for anything. So we found that surf therapy improved mental health outcomes for those individuals. We looked at folks who had, say, depression or PTSD, and surf therapy improved mental health outcomes for those individuals as well. In fact, the effects were actually greater. Then we compared folks who had 2 disorders to those with 1. And at a minimum, in one study, we found no differences. They both improved. Both groups improved, and there was no significant difference between them. And then in one study, we actually found that those with both disorders actually did better than those with one. That's a rare finding. Usually in psychotherapy, if you've got comorbid disorders, you don't do as well. So that was an interesting finding, but at a minimum, if you're talking no diagnosis 1 or 2, we're finding significant mental health effects for surf therapy across our populations. And so I love this because we were talking even today with Waves of Wellness, all the different types of interventions and tailoring it to different populations. And I think that that does speak well because the beauty of surf therapy is that there seems to be some general benefits to it. Sometimes we have these disorder-specific treatments for various disorders, and we can very much tailor surf therapy, but it seems like there's a lot of general mental health benefits to it. So this one will be interesting to see what you guys think about, in that there seems to be better longer term, meaning 3 months, better longer term benefits for programs that are delivered in 6 weekly sessions than in a week. So let me talk you through these graphs. The first one is our surf hike. And those lines are discontinuous merely because we controlled for the number of sessions in each time period, and so they're a little bit different. But what you see is that in both our surf and hike conditions, not only did folks improve over the course of the intervention, they continued to improve at 3 months. This is very interesting because we don't really see this even in the psychotherapy literature. Normally, when you discontinue psychotherapy, you bounce up. You don't go back to baseline usually, but you do kind of go up a little bit in your symptoms. But we didn't find that here. We actually found that people continued to have benefit at 3 months. However, a different pattern emerged with the National Veteran Summer Sports Clinic. And Van's here. So Van was actually volunteering with NVSSC the first year that I volunteered. So Van is, you are world famous for your work. So I just wanted to highlight that now that you were back in the room. What we found here is a little bit different. So our baseline, I will say, might be a little artificial. We assessed folks when they had already traveled to San Diego, were already in a beautiful hotel, and it was sunny and lovely. And so people's baseline may have not been a true baseline. But all of the outcomes that we're hoping decreased over the course of the week. But what happened at 3 months is that it actually was, they shot up beyond what they were at baseline. And so this is indicating that even though it was a week, there were great benefits for that week, but they weren't sustained at 3 months. So this goes back to that idea of more frequent engagement. Betty, I'm going to call another nugget because Betty calls it the local produce, that you need to find local produce that you can do in your neighborhood. So it may be amazing that folks fall in love with surfing, but if they can't do that at home, then that's a concern. And I know we've talked a lot in the last couple days about what other forms of relationships can you have with other types of water. We've talked about wave pools that are being developed. Absolutely, and that's part of the constellation. But it also needs to be something that we need to think about in terms of sustainability and getting people to be active and engaged on a more frequent basis. And so when we tend to look at these, there seems to be something with more frequent repetitive engagement that there's better benefits than in a single week. And so I realize I am speaking at the Blue Mind Summit. And so we'll see what you guys think about this. But in our surf and hike study, we compared a number of outcomes. And by and large, they were comparable. There were a few differences, and when those differences existed, they favored surf therapy. But by and large, the psychological benefits were comparable between surf and hike. And some people may be disappointed in this. I certainly am not. We are in a mental health crisis. If all we have to offer people is one type of treatment, whatever it is, if it's just psychotherapy, if it's just medication, if it's just surf therapy, we have a huge unmet need. And so I actually was encouraged by this. Similarly, when we compared across our NVSSC 5 different activities, there weren't any differences. And you know, one of the things I was concerned about with our randomized control trial is to participate in one. You have to be willing to say, yep, whatever the coin flip is, I'm willing to do that treatment. And I was curious. I was like, are we going to have a bunch of people saying, absolutely not, I only want one or the other? Believe it or not, we had less than 2 hands worth of people who said that. I think it was only like 6 or 7 folks. And there were some folks that said, you know what? The water terrifies me. It is not calming to me. I do not want it. And other people said, hiking, that is so boring. I only want to surf. We did avoid that, just as a side note. We let folks, once they were randomized and they did the full course of the intervention, they were allowed to switch if they wanted to. And more people did either repeat or stay or switch to surfing than the opposite. So there might be a preference there. But we really didn't find differences. And so I think this is just really great in terms of, we know surf therapy works, so do other things. And, you know, just from a scientific perspective, what are some of the active ingredients in these interventions? You're outdoors. You're being physically active, you're with other people. We know that those factors alone can create huge differences in mental health for people. And so maybe the difference between water and not isn't enough to override those other important factors. It's also possible that there's other stuff going on that we didn't measure. And so that's a possibility too. But for what we know now, find what you like, find what you can do regularly, and go out and do it. Well, thank you. I wasn't sure how that was going to go over in here. I was telling a story that, you know, there were folks who were interested in our results, and then when I told them the results, they were no longer interested in it or covering it. So, you know, I never know what I'm going to get, and at the Blue Mind Summit, I wasn't sure. So thank you for that. So one important thing, and this has been super fun for me to hear over the last day. So in our intervention work, surfing is the intervention. You work one-on-one with an instructor, but there's no psychological component to the work that we've done. And over 90% of our samples specifically are already engaged in psychotherapy or pharmacotherapy. So they're already getting something else for our participants. So very much we recommend it as an adjunctive intervention. However, I think we have a lot of options here. And this was great with the Blue Mind curriculum yesterday in terms of there was a clinical and a non-clinical intervention, which is fantastic. Not everyone may need a clinical intervention. And I think where we need to go, and we've got a lot of work to do to get here, but it'll be really interesting to know who does just surfing in a supportive group setting, who does that work for? who needs surfing plus a psychotherapeutic component, who needs surfing plus full, therapy, and trying to figure this out. And so this has just been something that I've spent my career doing, trying to figure out who needs what. And I think that this is going to be a really important area. And so I loved hearing about the tailoring that's going on, because not everyone may need that, and that's okay. And so being able to fit what our populations need. And I also, Jamie, I love your work. So I do work that is kind of a little cut and dry because I work within the medical model, and I want the medical folks to listen to what we have to say, and I have to speak that language. You do all the interesting stuff of what's really going on for people and what are the mechanisms of change. And so I love that you're taking a look at that. And so Jamie does the more interesting stuff. I'm a little more cut and dry, but it would be really interesting to find what are these mechanisms that people need, what are the core components. And we were geeking out about it yesterday, having a dismantling study where everyone gets different components and whatnot, which would be ideal, but those require huge samples. So that would be a whole full ISTO, project if we ever want to do that. And so I think it's really wonderful that you guys are thinking about the populations that you serve and trying to fit, what do people really need? And so there's still so much to learn for surf therapy. I mean, I loved how Cash was talking about when he wrote his first book, there were not that many references. And then in the second one, there were so many. But we still have a ton of information that we need to learn. But I hope that these points lead you to think about your own programs. What are you doing? Are there any things that can be tweaked to deliver surf therapy better? I also hope that you think about, are there any changes that could be made? And how are you measuring your outcomes? So I joke that some of my research is, cut and dry, diagnosis or not, get it. And I get all the discussions about, do we even label people with diagnoses? I got it, really, I do. But if we want providers and insurance companies to take this seriously, we've got to speak the language. And so Dr. Ward, this was all last ISTO. He made the comment, we need to get our work into psychiatry journals. So psychiatrists actually look at this, and that we're not just publishing where, folks look at. We want to actually get to our target audience. And thanks to you, our surf hike study was published in a psychiatry journal, which I may not have immediately gone to. And so that was all you. So I love ISTO for that reason, and it is true. So for us, we have looked at common measures, common symptom measures, and that has allowed us to not only look across our studies, but we can actually take a look at what do our results look like compared to psychotherapy studies? What do they look compared to psychiatry studies? Because we're all using the same measures. And fully appreciate that we're looking at different samples. And so no one's going to be doing the diagnostic measures with kids or the self-report measures that I use with kids. But if we're looking across adults, there are measures that are used across nations that are translated. And so I think that the more consistency we can have in our measurement, the better able we're going to be able to say what we know and what we don't know. Because if everyone's using whatever measure they like or they're creating their measure, it's really difficult to compare. And when we're trying to, I won't get too sciencey about this, but one of our gold standards for data are meta-analyses. And you need to be able to have data that is consistent in order to do those. So that is my plug. There are constructs that we're still learning, and that you're going to have to measure things and come up with measures. Fully get that. But if there are certain constructs that exist in the literature, I highly recommend using those so we can actually compare. So that's my soapbox for consistent measurements. And that brings me to the end. So what kind of questions do people have? Thank you. You guys are all awake. Yay, thank you. So what kind of questions do people have? Yes. Oh, I'm not calling on you. Okay.
Hey, Kristen, thank you. Amazing presentation. And a personal thank you, because without our meeting last year, I wouldn't have gone down the road I've gone down and ended up here. So that was really awesome. One thing that I was really interested in, you mentioned about the 3-month follow-ups.
Yes.
And I think, correct me if I'm wrong, but I think from one of our chats, you also had a surf hike frequency questionnaire.
Yes.
And what made me think was when you mentioned about finding your own medicine. I couldn't remember the exact quote, but the thing that you can do more often.
Yes.
Did you find any relationships with the frequency and the results at follow-up?
Surprisingly, no. It was difficult one of the limitations was we asked for number of sessions, if they repeated the program, and then if they surfed on their own, but we didn't get the frequency or the number of sessions for each of those. So it was more of a dichotomous variable, which we know limits our ability to make sense of it. So they were not there. There's a point. We created those questions. They're subpar. And so the way we measured it, we didn't actually find that. Now, it could be that maybe something's going on at 3 months that, we didn't detect or something like that, but we didn't actually find that relationship. And like I said, it was more about whether or not they repeated the program. It would have been helpful to get number of sessions total and the number of sessions that they did on their own. So great question. So if you're doing that research, number of sessions in addition to whether they continued it. Yeah. Other tip, too, for anyone going forward, and I loved hearing it earlier today from Joel's presentation. One of the things that we didn't do that I always regret is that I'm a big, heavy quant person, and I didn't add qualitative data. But the fact of the matter is different data do different things, and it depends who you're presenting to. So to the best of your ability, even if you can have some fill-in questions, that would be a lived and learned lesson from our research efforts. So.
So my question was, you said that these participants were also concurrently in other clinical interventions, or they?
Most of them,
Okay,
yes.
so my question is, did you compare a control group treatment as usual versus those that got treatment as usual plus hike versus surf? Were there differences?
No. And so one of my dream projects is looking at folks who get evidence-based psychotherapy alone plus evidence-based psychotherapy plus surf hike. Let me explain why we didn't do that, because that was an intentional decision. When you're working with the military, folks have national security responsibilities. And so we did not want to limit care that could affect them getting back to return to duty. And so, we did not have a treatment as usual condition for that. And so both folks got their normal standard care plus an intervention. Great question, though. Yes?
Thank you. That was great. So, a couple questions.
Yep.
There's the veteran aspect and there's the active duty aspect.
Totally different.
Okay,
too.
so
Yep.
the National Veteran Summer Sports Clinic, obviously, we're veterans, and with multiple different types of standards, the reason why they're there.
Correct.
Either physical, mental, or emotional, whatever. it
Yes.
was. Then the other ones that you did, the active duty, Did you determine how long they were in the military? Were they transitioning out? Were they at different levels in the military, such as rankings and also combat experience? Does it identify in any of your studies the differences between this, or is everyone all together?
Thank you for raising that question, because I don't know that I specifically said it. So for our first study, anyone could have a physical or psychological reason for referral. So that was a pretty general general sample of active duty service members. In our surf hike study, everyone had a diagnosis of major depressive disorder in that study. In terms of your questions about rank, by and large, most of our participants were enlisted. There were a few officers or warrant officers, but by and large, mostly enlisted. And the average age was in the young 30s. So there was a combination of folks who were fairly young with those who were later in their career. Did that answer your question? In terms of combat, I don't know. We didn't find any differences on combat, but I also think it was a heavy combat sample. We had a mix of, in terms of traumatic experiences, the most common were combat or military sexual trauma.
Well, I was wondering if there's different levels of exposure
Yeah.
during the time and your
Oh.
responsibility duty. So I'm not saying basically the difference between enlisted and officers. I'm talking about people that have been in the military for a certain amount of time, have different jobs, have different responsibilities, and longer exposure at the trauma that you've seen. I was wondering if it was all one, or did you actually identify, the separate?
We looked at a lot of different groupings, and with our sample size, there wasn't anything that panned out in terms of those differences. But you're absolutely right in terms of thinking about an active duty versus a veteran sample. Inherently, there can be differences there, and obviously cohort effects when you have people who likely served in a higher up-tempo time. Yeah. Yep. Absolutely. So another point for why these aren't direct comparisons, because they aren't the same sample at the same time. There could be other things going on. But despite the differences in these studies, these were common patterns that emerged.
The reason why I asked that
Yeah.
is because the higher exposed some of the trauma,
Yeah.
if there were studies based on their effect of their exposure to this stuff, might be largely more looked at due to their job of what they were in the military versus someone that was brand new that didn't experience that. I'm sure that police officers in this world can probably understand what I'm talking about. And so one traumatic experience versus multiple throughout years. I was just wondering if there was any look at that.
Sure, and there's also the consideration of, even among military trauma, there are people who have had prior trauma prior to entering the military. And so even if the military year exposure difference, it could amount to the same time given civilian or childhood trauma too. So, but these were not primary PTSD studies. So much of the work I do is primary PTSD studies. These were not PTSD primary studies. 2 general samples, and then the one was major depressive disorder. And so we did assess for PTSD, we did assess for trauma exposure, but that level of nuance, like years of disorder, years of symptoms and whatnot that we often ask in our PTSD studies, were not asked in these. Great questions, though.
We've got a question from online, actually.
Ooh.
So hello and thank you to everyone who's logging in
Thank you to
online.
everyone live online.
And this question was actually about your comment about measures.
Okay.
And just the question is, are there standardized measures you would recommend that are accessible to anyone? Because some measures are behind paywalls, or locked away and very difficult to access. what would you? Are there any in particular you'd recommend?
Are they asking for any particular condition or set of symptoms?
They're not at the moment, but that could come in, and if it does, I will let you know. But
I can just rattle off a few. If you're looking at psychological symptoms, the PTSD checklist is used very commonly in PTSD research transnationally. The PHQ, the patient health questionnaire, assesses depression among other symptoms. The GAD-7 assesses anxiety symptoms. And the PANIS is a good one, which is positive and negative affect. And you can split those into 10 questions of each. We used to do the PANIS, just the positive aspect before and after. One quick point I wanted to make about the complementary treatment with complementary treatment with surf therapy and psychotherapy. One of the cool findings we found with our surf therapy research that we don't often find in psychotherapy is that we were actually, it's easier as a therapist to reduce negative than add positive. And one of the things with surf therapy is we were able to increase the positive, which is not easy. So that's awesome and highlights how there can be a really nice complement between the interventions. That it augments something that we're not getting in other types of care. Similarly, there might be things like guilt, shame, blame that maybe need some work done in an individual setting or some other type of therapy setting. And so I do think there's a really nice way that they can complement one another. Anything else?
There's one more question.
Hopefully I answered the one online. If there's any other questions about that, feel free to email me or any specific symptoms.
You made a really interesting comment about the inflated baselines after being in a nice hotel. Could you maybe speak to how you controlled for that in the hike trial? And actually maybe just, because obviously there's lots of practitioners in the room who are maybe using the evaluation framework or something similar to run their own evaluations without academic support. What kind of steps can you take to control for these sort of baseline confounds?
Absolutely. So that was a big confound in that people were not from San Diego. They traveled to San Diego. They were in a nice hotel. They were all excited. So that one, I think, could have been artificially inflated. For our surf and hike studies, what we did was our very first study, our program evaluation, they did the baseline on the day that they arrived to their first session. However, we switched that for our surf and hike study, and we met with them at some point in the 2 weeks prior to their first session. So that way, we just got a daily baseline. If you had a bad day that day, someone had an awesome day, you cancel each other out. Not everyone's like, yay, I'm here to do something outside and active today. And so I would recommend, if that's feasible, and you can bring folks in at some other point or meet with them in the week or two prior, that might be the best way to do it to reduce those effects. That's a terrific question.
I think that's all we've got time for. So just once again, a massive thank you, Kristen.
And thank you guys for your attention and interest, for all the work you do, and for welcoming me, even though I'm a little bit of an outsider coming in. So thank you guys.